continue a lovely trend at Sky and being timely. So it's my pleasure today to welcome Dr. Smitha Banerjee to School of Communication and Information. Smitha is one of our graduates from 2005, so some of you may have met her previously, and we're delighted to have her here. She is the equivalent of an assistant professor. The terms are much more technical where they happen to be, but she's an assistant professor on the faculty at Memorial Sloan-Kettering in New York. She has more than 30 publications to her name and is working a lot in cancer prevention. So she's been working in indoor tanning, in smoking, and in
smokeless tobacco
use as well. So she's applied to the National Cancer Institute for funding and has some pieces that are, awaiting funding decisions. So we're very proud of her and very delighted to have her with us. She is a part of a program at Memorial Sloan-Kettering that is called Comskil. So that's the easiest thing to call it. But it is their physician training program. And that's a part of what she does as well. She has a half of a life in prevention and part of her life that's also in communication skills training for physicians, and they have a rather unique program. So we are having this talk as a part of our interpersonal health communication series, so part of our class that's going on as well. We're going to have a presentation, open it up for questions afterwards, and then we're also going to continue class if anybody would like to continue and move along in that direction. So please join me.
Is this going to be on the exam now?
Write exam questions for us, and especially for the questions afterwards. That's going to be the highlight of the exam.
Right.
So anyway, I want to thank everyone for coming, and please join me in welcoming Dr. Banerjee back to Sky.
Thank you, Dr. Green. So, thank you so much. Dr. Green took us to a heavy lunch, and after that, it's so difficult to give this presentation, but I'll try my best. So, initially, this whole talk was, I was going to talk about how we've done this training program for oncology doctors. But we've now expanded the program, and we are doing a lot of training for inpatient and outpatient nurses. And that's why I changed the title of the program a little bit of this talk. And now I'll talk about the development and implementation of an institution-based communication skills training program for oncology healthcare providers. So, which includes physicians, inpatient nurses, outpatient nurses, and also some social workers. So let me just start with a few examples. So Mrs. Williams' recent diagnosis with stage 2 colon cancer has left her confused and uncertain. She has received differing opinions on whether to have adjuvant chemotherapy and wonders about the possibility of a clinical trial. She wants to be involved in the decision and desires to find a doctor she can trust. Similarly, this is another example. Mr. Jones' pancreatic cancer encased the mesenteric artery, rendering the diagnostic news more challenging because his tumor was inoperable. How long do I have? Will I suffer? He wonders. Fearing pain during his dying process, he wants to discuss what to expect over the last days of his life. Who will speak to his wife? Who will speak to the young children? Should he seek hospice care or die at home? Now, challenges such as these are presented every day in numerous settings within our cancer center. Doctors, nurses, social workers, on a daily basis, they are faced with a lot of difficult questions such as these. What would you do if it were your mother? And asking the doctors to make a decision. Can you please avoid using the word cancer around my father? Again, with a lot of cultural changes, we do get patients and families who don't want the patient to know that the patient has cancer. They've come to a cancer institute, but especially if they've come from another country, one of the big things is not to tell the patient that they have cancer. How do you deal with the ethical dilemma of this? Aren't there any other treatments you can try? Again, one question, especially when patients are being moved from curative treatment to palliative care. We came to MSKCC thinking this was the place. Isn't there anything else you can do? Is this the end, etc.? How long do I have to live? Am I going to die? So again, these are just some kind of questions that are encountered by the healthcare providers on a daily basis. Now, challenging communication is present in cancer consultations. It could be challenging because it's emotionally charged bad news. You're telling somebody for the first time they have cancer or that the cancer has spread. There's a lot of uncertainty, what's going to happen. There is threatening prognosis, burdensome treatments, you're going to have so many side effects, and despair at the end of life. And therefore, these conversations are indeed very challenging. Now, there is some communication skills training in medical schools, but this is on very basic communication skills. However, an applied curriculum that addresses some of the issues that I just mentioned, it's needed in cancer centers. And I'll talk about this in greater detail as we move forward. Now, there's an increased recognition from a number of national institutes that quality healthcare requires patient-centered communication. And again, there's a lot of funding, there's a lot of research happening in this area. There was this latest article in Wall Street Journal about improving the ways doctors communicate with their patients, and it could lead to better healthcare and lower costs. Now, talking a little bit more about communication and cancer care, there are distinct features of cancer care which include diseases that are both life-threatening or potentially curable, numerous and changing clinicians making up a healthcare team. So you might be seeing an oncologist, you might be seeing a surgeon, a radiation oncologist who's giving you chemotherapy, as well as you're meeting with chemotherapy nurses, you're meeting with social workers, you're meeting with case managers. So the team that is taking care of you is built up of a lot of different professionals, and that can make communication difficult. There are multiple treatment modalities, so the same person may be having surgery followed by some chemotherapy as well as going for radiation. So there are multiple treatment modalities for patients. And there are long periods of uncertainty following treatment. So you've had a biopsy, you're waiting for the results, and that could be a very traumatic time. There's a lot of uncertainty around that, around what the finding is going to be. So quality healthcare requires patient-centered communication. Again, I cannot overemphasize this. Cancer patients report, a lot of research has shown that they report significant levels of unmet need in the realms of communication, specifically in 3 areas. One is information provision. So different team members are telling the patients and families different things. What do they believe in? What is the right thing? Again, so there's a lot of confusion about information. They need a lot of psychosocial support. Especially the family members, and when patients are in the ICU, the family members are going through a very traumatic time, so there's a lot of psychosocial support required. And as well as they need somebody to respond to their emotions, which some people completely shy away from. They're uncomfortable with it, and so there are a lot of significant levels of unmet needs. Now, medical schools and residency programs do train students in basic communication skills. However, an applied curriculum that addresses these issues in cancer care, it's extremely important. Although there are some immersion courses that show that people can improve their communication skills, but what is important is to pay attention to this hidden curriculum. So let's say we have a bunch of fellows who go through the program. We are teaching them, instead of asking closed-ended questions, ask open-ended questions so that the patient can tell you a little bit more about how they're feeling. So instead of saying, did you sleep last night? It will be better to ask them, how was your sleep last night? So letting them elaborate a little bit more. Now, so this is what we are teaching them. They go back into the practice, and the attending has told them, you only have 15 minutes. Go in, do what you have to do, and you should be out in 15 minutes. And so they are caught in this flux where they want to go out, talk to the patient, but they also think asking open questions is going to take a lot of time. Should I even talk about emotions and how they are feeling? It's going to take so much time. I have to be out, in and out in 15 minutes. So what do we do there? So attending to this hidden curriculum is extremely important. So what we've realized is when we built up this program, what is important is to train the physicians. If the physicians and the attendings are trained, they can be a voice for the program. They can talk about the program, they can encourage faculty and their young fellows to participate in the program, and then adhere to some of the recommendations that we are making in terms of improving communication skills. So today, what I'm going to talk about is, I'll talk about our Comskil training program at MSKCC. I'll talk about the rationale behind it. I'll talk about what we include in terms of curriculum and training. I'll talk a little bit about evaluation. We'll talk about what we do to do faculty development and some of the research that we are doing in Comskil. So our lab was actually founded not too long ago when I finished my PhD in 2005. It is housed in the Department of Psychiatry and Behavioral Sciences. Now, the way Sloan-Kettering is set up, it is, if you haven't visited it, it's interesting. The main hospital, it's spread out in New York City. So the main hospital is on the 68th Street, and then all the different units are in different places. So we are located on 54th and Lexington, and one of the initial challenges was to get people to come from there and come to our site for this training. So they were almost losing their entire day coming, doing the training, and the training is a day-long training. So initially we had some challenges with respect to getting people to come for the training, but when we got some senior faculty members to come and advocate for the program, it became much easier. So the mission of our program is to work in partnership with clinicians of all disciplines to improve communication with cancer patients, their families, and therefore enhancing the overall adaptation to the illness. Following this, the Comskil training program, it's designed for healthcare professionals to improve communication with patients and families. Now, when we started out, it was only started out for faculty members and attending doctors at Memorial Sloan-Kettering. We did a lot of pilot studies, we collected some data, and we were able to get an NCI grant to do this training for a 5-year period with all the fellows that come into MSKCC. What we are doing now, we've got some philanthropic grants to diversify and develop this program for inpatient and now outpatient nurses. We've also have a recent grant to do this with pediatric nurses. So we are developing the program to see what their needs are, what is it that they require in terms of communication, and then we develop the program for them. This is an evidence-based approach. Again, our data shows that people do increase their communication skills. How does it translate to patient outcomes is another story, and I'll talk about this as we move forward with this. There is experiential and reflective learning. So we have a module-based program. There are different modules which are taught to different disciplines. The way one module is taught is we start with a didactic lecture which lasts about half an hour to 45 minutes, and then the group breaks into small group role play rooms and they practice what they've just learned. So they do a lot of role plays with simulated patients. So there is experiential learning, as well as there is a lot of reflection on what they said, how the other person reacted. There is video playback, and so there's a lot of reflection on what they said, why they said it in a certain way, what would change if they had said it in a different way, and so on. And I'll show you some examples of what we do. So in terms of the lab structure, we have a teaching theater where we do all the didactics. We have 6 role play training rooms with 2 cameras and playback facility. So this is what our small group role play room looks like. Now, one of the things that we aspire to do, and again we are able to do this at 90% of the time, but not all 100% of the time, is do co-facilitation. Now again, these the modules that we teach and the examples that we use for role plays, they're very medical examples. So let's say if we are talking about prognosis, or we are talking about transitioning to medical to palliative care. Our simulated patients, some of the discussions may become too medical or technical, and the faculty who's in the behavioral sciences, they may not be very well equipped to answer all the questions. So for example, if I have a PhD in communication, but I don't know anything about medicine or cancer, and if the fellows start asking some very specific medical questions, I wouldn't know what to do. And so what we aspire to do is have a co-facilitation, have 2 facilitators doing the role plays, where one is a clinical facilitator, and same as the fellows training group. So if the fellows come from neurology, we want to have an attending who's a neurologist, as well as have a psychosocial facilitator who will help use the Comskil language, because otherwise the language that they use may be very medical, and again the discussion can soon become very medical, nothing to do with communication skills. And so we try to do this on a dual facilitation basis, and that's what this looks like. So this is an example of our small group role play room. So the rationale for Comskil training. I'm going to talk about 3 issues. I'll talk about the importance of communication to outcomes. I'll talk about the fact that communication is not always optimal, and that communication skills can be taught and evaluated. So now researchers have been studying communication in physician-patient consultation for many years. Currently, research in this area is multidisciplinary and multi-methodological. As this research has progressed, a considerable body of evidence on the best practices in physician-patient communication has amassed. This evidence provides a foundation for our communication skills training. Now, from the research that has happened, good communication skills have been linked to desired patient outcomes such as increasing patient understanding, increasing patient satisfaction, reducing psychological distress and anxiety, and also related to fewer physician malpractice claims. So communication skills do go a long way. However, research in physician-patient communication has also shown that there is room for improvement in the way physicians talk with their patients or the family members. There was a recent review of literature, and I'll tell you who did it in a minute, which indicated that cancer patients, they have a lot of unmet communication needs in terms of getting information about the extent of the disease, what's going on with them, prognosis and treatment options, intent, and also side effects of the different treatment modalities. Other areas where research has demonstrated a need for improvement is seeking consent to clinical trials, recognize and responding to patient cues for information and emotional support, soliciting patient consultation agendas, delivering prognostic information, responding empathically to patients, checking their understanding. And this is one of the big things where you go in and you plan to talk to the family about a do not resuscitate order, and you realize that the family is completely not in line with what the physicians are thinking. So they are thinking, we're going to be okay, our mother of this, and we'll be able to take her back home, where the reality may be very different. So a lot of it is about checking their understanding to make sure everybody's on the same plane, encouraging patient asking questions. We try in our Comskil training program to address, I wouldn't say all, but most of these concerns in different ways, and I'll talk about this. Now, communication skills can be taught and also be evaluated, and some research has shown that they can be effective. The most recent review was in 2013. It was a Cochrane review. They included 15 studies. 11 studies compared communication skills training with no communication skills training. 3 studies compared the effect of a follow-up after initial training, and that is one thing I would like to talk about at the end of the, after I stop talking and giving this presentation, is about follow-up and consolidation training. Because one of the things that some of our training directors are talking about is fellows come, they go through this whole training, they do all the assessments. Some of the people, if we do a percentile ranking, some fall short of a certain level. What do we do with them? If we were to consider this as a school, then these people have failed. Do they come back for training? Do we give them some booster sessions? Or do we just let them go? Or we just say, okay, they've completed the training, they have a certificate of completion, now you can go back into the community and start treating patients. So what do we do with this? So that is one of the question marks, and we're trying to reconcile and come up with ways of what to do with these fellows. But that's something I'd like to discuss a little bit later.
Can I ask you a question?
Yes.
When you do the assessment, is the piece of paper or?
So there are multiple levels of assessment, and I'm going to talk about assessment in a minute. All right, so overall research did not show too many effects. However, what was statistically significant was open questions. They were able to ask more open questions and show more empathy towards patients. But the studies did not lead to greater patient satisfaction, reducing patient anxiety, and so on. And we'll also talk about why that may be a problem. So talking about coming down to the nuts and bolts of what we do, what our curriculum, Comskil curriculum and training is based on. So the foundation are based on 2 communication orientations, comes from sociolinguistic theory, and one is the position-centered approach, the other is the person-centered approach. The former relies on a restricted focus on the discussion about diagnosis and treatment as a predicament that the patient is expected to negotiate, understand, and learn about. The other one is supposed to be more person-centered, where you tailor the information that you're going to give to the patient or the family members. Again, the whole focus here in our Comskil lab is to try to encourage fellows and doctors to engage in a person-centered communication. Now, our teaching modules, they are based upon this Comskil conceptual model. It's a skill-based approach. We teach skills, we tell them specifically how to say things, what to say things, how to phrase things, and again, they may be different depending on the context of the consultation. We started with 26 skills, but now we've, after a lot of research, we've realized that some of the skills, actually people don't really use them. So we've come down to 20 communication skills, which are organized into 6 categories. So this is what a conceptual model looks like. You start with the communication goal. What is it that you want to achieve in a conversation, in a consultation? Now, in order to achieve a communication goal, we recommend certain strategies. And then we break down the strategies into specific skills and process tasks. So going into specific definitions, a communication goal is the desired outcome of a consultation. What is it that you want to achieve in a consultation? For example, for something like breaking bad news, the goal should be to convey threatening information in a way that promotes understanding, recall, support for the patient's emotional response, and a sense of ongoing support. Now, as I said, these goals are achievable through communication strategies. And these are complex plans that direct communication behavior towards the successful realization of a goal. So we can say that, okay, you want to break bad news, offer ongoing support, and promote adaptation. Now, how do you do that? So again, this is still in a more abstract sense. We break it down into nuts and bolts and specifically suggest what to recommend, what to do. So we break it down to skills and process tasks. A skill is a standalone utterance by which a physician can further the clinical dialogue. So we'll say, first check their understanding. Make sure that what they know and what you want to tell them, you're on the same page. So they know that the mother has stage 4 lung cancer and that the cancer has spread. This is what's happening, so that you want to make sure the patient and the family are on the same page. In order to achieve complex communication strategies, it is essential to use appropriate communication skills. Now, our skills are broken down into 5 big categories. The first is agenda setting, where you want to set up the agenda, make sure that the conversation that you're going to have is kind of previewed and discussed up in the beginning. Questioning, using good questioning skills to make sure you're asking what you want to ask and you're answering the questions that they want answered. Checking in with them to see if the information that you're conveying is understood by them, if they are ready for that kind of conversation to happen. Again, sometimes patients or the family may be too distraught, or they may not be ready to have a conversation, or they might be waiting for a family member to be present when the conversation happens. So again, checking preferences. So a lot of checking skills. Information organization. How do you organize? How do you summarize information? Previewing information, and so on. And being empathic while having all of this communication. Now, this is just a little menu of different skills that we teach, and I will not go into detail of this, but again, it just shows you that when we do our communication skills training, we focus on these skills, all these skills. The second aspect is process tasks. These are sets of verbal or non-verbal behaviors that create an environment for a conducive conversation to happen. So again, these also include behaviors that you should not do, that should be avoided. For example, we'll suggest you should categorize information, sit at eye level with a bedridden patient, avoid use of a lot of medical terms and jargon. Although these process tasks are important, the focus of our training is more on skills, and we try to focus more on getting people to say certain things, to use skills in specific manner. Now, we have different training modules for physicians and for inpatient and outpatient nurses. For physicians, here, so modules are almost like courses. So these are the courses that we have: breaking bad news, shared decision making about treatment options, responding to patient anger, discussing prognosis, discussing the transition to palliative care, discussing death and dying, working with interpreters, conducting family meetings, and transition into survivorship. Now, depending on what training program they come from, it's a different mix. So, for example, for somebody coming from radiation oncology, they may be taking breaking bad news, shared decision making, anger, and prognosis, while somebody from medical oncology might be doing different. So depending on the training program that they come from, they do different combination of courses. We have recently, only since a year and a half, developed this program for inpatient and outpatient nurses. So we did some focus groups with nurses to find out what their needs were in terms of unmet needs in terms of communication. And after all these focus groups, we came up with these 3 courses, modules for challenging interactions with families, which they said was a big problem. More than interactions with the patient, it was the family members and dealing with them that was problematic. And so we created a module for that, responding empathically to patients and discussing death, dying, and end-of-life goals of care. And I'll show you an example. Oftentimes, the physician comes in, has this whole talk about DNR, death and dying with the patient and the families, and the physician leaves, leaving the families in shock, in distress, and with a lot of different questions, which at that time they didn't know, or the questions didn't come to their mind. And who do they go to for answers? They go to the nurses. And the nurses said, a lot of times we feel, we don't feel equipped well enough to have these conversations. How to deal with the emotional impact, what to tell them, because we think it's the physician's job. And so some nurses will just run out and get their supervisors, or make a call to the physician again to return and have these conversations. But we said, you're there, you're working with the families, they need to be equipped to have these conversations. And so this is another big module that we developed for both inpatient and outpatient nurses. So the way our workshops are formatted is we send out booklets about 2 weeks in advance, depending on whatever module we are going to cover for that particular day. There is didactic teaching presentation. We go through the literature, show evidence. There is group discussion. We show them strategy, how to achieve a strategy through use of certain skills and process tasks. And we show them certain exemplary videos. And I'm going to show you a couple of exemplary videos in a minute. Then we break them into small group role play rooms where we have our simulated patients. These actors have been working for us for many years. So they play the role of simulated patient. They interact in a role play with the learners. There is a facilitator who moves these whole conversations forward. There's a lot of reflection on what they did and why they did. And there is video playback. So I'm going to show you here, this is responding to patient anger. So when we come down to strategies and skills, the 5 strategies that we recommend are: allow the patient to recount grievances, work towards a shared understanding of the emotion or experience, empathically respond to the emotion, explore attitudes and expectations leading to anger, and facilitate coping and connect to social support. So when somebody comes for the anger didactic, after doing all the literature and showing them evidence, we break it down into 5 skills. We say you can control somebody's anger by using these 5 skills, by using these 5 strategies. We talk about the different skills that go under each strategy, and then we show them some exemplary videos. So I'm going to show you the first one, allow the patient to recount grievances.
Good afternoon. Good afternoon to you. Thanks very much. You have ruined my life. I've got this hole in my side. Look, it's like I had a perfectly good working bladder before you started all this. And you said I had to have my bladder removed. And I know now that I didn't.
What information do you have that's different from how long we last spoke?
I saw a very, very good program on Fox 5, and they said that this kind of cancer, the cancer that I've got, that you said I've got, their expert, a real expert, told me that I could have had it just watch and wait, and I didn't need to lose my bladder at all. That there was no risk with watching and waiting. They're real experts. They have real doctors coming on and telling you what's going on. and you just misled me. You
Rubbing it in a little bit more.
Things changed since I lost my bladder. I've got this hole in my side. It's weird. It's absolutely weird.
And this is one of the mildly angry patients. This is what we hear. In real life, they get to meet families and patients who are very, very angry. So anyway, so the first strategy is allowing the patient to recount grievances. We talk about different skills that may be important and so on. And the second strategy is to work towards a shared understanding of the emotion. And another example.
Obviously, are very frustrated, and I want to better understand what you heard on the tell you about bladder cancer?
Don't you listen. I said they had a machine that could look at your bladder, see what was going on, and that they could take little bits, and that you didn't have to have your bladder removed.
So if I'm understanding you correctly, on
Be the first time.
on the news piece, the reporter said that there were some types of bladder cancer that could be taken care of without having your bladder removed.
And that's mine. And you took my bladder away.
And what was your understanding as to what I had said to you at our first consultation?
You said that I must have my bladder removed, because it would spread to cancer, it would spread all over my body, and that well, we all know that.
So these are just some examples of the videos that we developed with the physicians and with the simulated actors. Now, the content of these discussions varies from who the training program is geared towards. So this is an example from doctors and fellows training. We also have a program from nurse training, and one of the big things, as I said, was they find it extremely difficult to have these conversations about end of life. And you'll also see the difference in the video quality. This is something that we just, in the last 1 year, video recorded and got it ready for this training. So this example that I'll show you is an inpatient oncology nurse having this conversation about end-of-life goals of care with the patient herself. What I'll show you exemplifies strategy 1 and 2, so establishing the relationship and developing an accurate shared understanding of the patient's situation, disease features, prognosis, and psychosocial needs and concerns.
It's a pretty tough conversation. Did you expect it? Was this what you expected when you visited it? No. I'm ready to die. Oh, I'm so afraid. Oh, what am I going to say to my daughter? Tell me what you heard in this conversation. What did you hear? What did you hear? I heard them say I'm going to die. I'm so frightened. My husband died a horrible death. I don't want to be in pain. Oh, I'm so scared. Let's take this step by step, because you're saying a lot of things that are worrying you. Let's take it step by step, okay? Tell me what it is that worries you the most.
This is the maximum. So this is just an example of the first strategy, exemplifying the first strategy. Hang on, let me see, how do I... Okay. So this is from having the discussion on establishing the relationship and getting to come to the shared understanding of what's going on. All right. So after the fellows or whoever the learners are, they see these videos and the didactics, they go into small group role play rooms where they practice using new skills. So checking understanding, let's say somebody's never used, they use these skills. They receive feedback from peers and facilitators on use of these particular skills. They view video playback. They observe peers demonstrating similar skills, and they learn the process of self-reflection. And role plays are a big part of teaching our curriculum, teaching the modules. The didactic typically runs between 30 and 45 minutes, and the role plays go on for about an hour and a half, Nicholas, if I'm right? Hour and a half. So and we only take typically three learners per room, so that everybody has at least half an hour of practicing the skills that we just talked about. Now, so I've talked about our curriculum, training, and the rationale. I'll talk a little bit about evaluation and answer some of the questions that you had. So there are challenges when we talk about developing evaluation. One of it is we want to make sure we are assessing what we are teaching them. Now, this curriculum, as I told you, is modular course-based. But our assessment could not be course-based, because when a patient comes in for a consultation, it's very hard to mark it as a breaking bad news consultation or a shared decision making. In the same consultation, they may also ask questions about prognosis. They may also ask questions about what treatment modality to choose. They may also ask questions about how to give this information to other family members, how to involve kids, and so on. So it's very difficult to assess a module-based real-life consultation. And also how to validly assess what is taught across 6 different context-based modules. And so I'll talk about how do we do the assessment. Now, there have been some previous models of physician-patient communication, but these models seem biased towards a consultation where the patient's problem needs to be diagnosed, understood, and then managed. Things are different at a cancer institution, because sometimes a typical cancer patient at a comprehensive cancer center will come to a first visit to a doctor where they already know what the diagnosis is. So it's not about diagnosing the problem, it's about where do we go from here. And so some of these models don't really work well with what we do. There have been some assessment tools. However, they evaluate general communication, not really the research questions, and adapting that to what we are teaching them. They tend to be more descriptive rather than evaluative, and their codes may not match what we are teaching them. So we had to develop our own. So our Comskil, our conceptual curriculum model allows for contextual teaching with skills-based assessment. It defines 20 discrete communication skills which are presented in the beginning that are used as the foundation for this contextual module. Participants are repeatedly exposed to these skills over the course of the evaluation. So what I want to say is something like setting up an agenda before you meet. It is a skill, but we'll keep re-emphasizing the skill for every module. So we'll say when you go in for a prognostic discussion, or when you're having a meeting about breaking a bad news or transitioning from curative treatment to palliative care, set the agenda first. So it's the same skill, but it's repeated over different modules. Not all skills are repeated for all modules. It is it's context based. So the Comskil conceptual model gives us the flexibility we need for assessment while making explicit a standard set of skills that could be taught and practiced over the course of the curriculum. So what we measure the learners on is skills, uptake of skills and use of skills. And I'll talk about our coding and how we measure skills in just a minute. This approach allows for a common skill vocabulary to be used during training, feedback, and assessment. We want to make sure when the learners come in, they're used to a very different medical jargon or using. So we have to train them to use our communication skills language. And we do that by not only training the fellows, as I was talking about the hidden curriculum, but also training the attendings so that everybody is using the same language, and that's the language used for assessment, that's the language used for feedback and for training and teaching purposes. So we follow the Kirkpatrick's triangle, and we do assessment on 4 or 5, I would say, different levels. The first level is the basic level. It's the evaluation of reaction. So learners' reaction to a curriculum, to a training is evaluated, and things like how was their learning experience, course evaluations, organization of the course, presentation content, teaching methods, quality of instruction, etc. So we assess surveys. Okay. So these are surveys which they do after every module. So they come out of a module and they'll fill out a little survey. Level 2 addresses changes in learners' attitude, knowledge, and or skills. So again, they do this before and after participating in a training. Level 2A focuses on learners' self-efficacy and changes in attitudes towards skill or using a specific skill. So we'll ask them their confidence level about having a conversation about DNR or death and dying prior to the training and after the training, and we measure that. The level 2B is it includes measurement of knowledge and skill level. How we do skill assessment is after they've gone through a training, the learners engage in simulated patient assessment. So they go into a room with a simulated patient, they are given a script, and they're asked to have a conversation for about 12 minutes. We video record that conversation, and then we code that conversation for specific skill usage. And then we want to see what they just learned, were they able to apply those skills in a test sort of a format. So that is immediately done after the training. So we do this assessment before training and after training. So before they go training, they have a role play scenario, they engage in this conversation with a simulated patient, and we do this twice before training and twice after training. The next is evaluation of behavior, where we come to the real world, which is clinic consultation recording. So these learners, whether it's fellows or nurses, they go out in the real world and they're having clinic consultations. After permission, taking all the consents, we video record these consultations and then code them for specific skills usage. And we want to see the skills that they just learned and applied in a simulated setting, are they able to transfer using those skills in a real clinic setting? So that is level 3 evaluation of behavior. Level 4 is evaluation of results and patient outcomes. So after a patient has had a conversation with a learner that was video recorded, we ask the patients to fill out a survey about their satisfaction with the consultation and a number of different things. And I'll show you some examples of things that we measure on the survey. So it's the 4 level of evaluation that we use for our assessment. Let me show you just some examples of how we use these. So again, this is from a paper by Brown, Byland, etc., et al. In 2009. So module evaluation are things like, I feel confident that I will use the skills I learned in this module. This study was done with 142 clinicians participating in a prognosis module. So how much they liked the course. So this is level 1A course evaluations. Next example is pre-post self-efficacy, and this is 40 multi-specialty healthcare professionals from the New York metro area. They attended a communication skills training module at MSKCC about how to conduct a family meeting in oncology. And these are some of the pre-post results about how confident they were about conducting a family meeting. Level 2B and level 3. For this, the standardized patient assessments as well as the clinic consultations. We code these consultations on all the skills that we teach. And then we measure pre and post and see the difference and see if it was significant. So this is how we do measurement of level 2B and level 3. So this is extremely time and this is resource intensive because you have to go in, listen to every consultation and then code. And Nicholas can answer a lot of questions about coding because he's one of our primary coders and he does a lot of coding. And level 4 is patient outcomes. These are 22 Likert type items. Again, it was the faculty designed these items. And some of the example items are: the doctor understood how I was feeling, the doctor seemed hurried, was willing to discuss my worries and fears. We framed these questions so that they go in tandem with what we are teaching them. So this is the level 4 data.
Is there pre and after?
Yes, so this is how our, this is what the research design is.
No, I mean the patient outcome measurement.
Yes.
Is it pre and
Yes, it is. It is. So pre-Comskil training, a month before training, again, this is ideally, this is what we aspire, but sometimes given their the rounds and schedules, this is not always possible. But we try to aspire to get 2 video recordings of the trainee in clinic with patient, so a real life recording. 1 survey per 2 different patients who are in video recorded in clinic. 2 standardized patient assessments when they go into a room and with a simulated patient they are doing that conversation, and standardized patient assessment checklist completed by actor about how the conversation went. Then they come into the curriculum, and these are some of the modules that they may study or that they may be trained in. And then we have post-Comskil training, which looks exactly like pre-training, 2 video recordings of the trainee in clinic with the patient, survey for both the patients who were in the clinics, 2 standardized patient assessment and standardized patient assessment checklist completed by the actor. So this is what the research design of the training and assessment looks like. Now our coding system. Yes?
Do you do any kind of evaluation or assessment, like organizationally? Are there like less patient complaints? Are people in general happier?
We are moving towards. We haven't done that, but we are moving towards that, because this program has been in place since 2005, and we want to move towards doing that. Initially, when we did the program, it was on a more pilot basis, so we were trying different things and then changing things because something was not working. Since we've received the grant, we are in our third year, right? Yes, we are in our third year. So at the end of the third year, we want to do, after we do all the data collection, is track complaints, etc., and see if there was a change. Again, that was not our primary aim, so we are not really focusing on that, but we do want to see a hospital-wide impact if there has been one.
The pre and post surveys are with different patients, though. The different patients,
Yes.
different two patients here than the
Totally,
two here.
totally.
So it could be also the particular patient is.
It could be. It could be. So it could be the context of the consultation, but we are doing this with multiple fellows. So at the end of the training, we would have trained about 500 fellows, and then doing 2 patients per fellow. Yeah, ideally there's randomization, so ideally we would have answered those questions. So we code the frequency of use of, instead of 26, it should be 20. It was 26 in the beginning, 20 skills and pre-post training assessments. So we code them in clinical video recordings and standardized patient assessments. There are 2 people. So the way the coding is broken down, we have 2 main coders. They code 20% of these video recordings. And then together they code 10% of the recordings, and we do a reliability check on that. And wherever there is disagreement, I go in or somebody else goes in to resolve that disagreement. And then they go and do 20 more. And so that's how we achieve 100% coding.
Do you have a sense of where your disagreement in coding is coming from? Is it a particular feature, or it's not a particular item that operationally is hard?
No, it's because this coding is extremely difficult because it's a conversation, and you're pulling out. Yes. You're pulling out what the learner is saying, what the doctor or what the nurse is saying, and then giving a name to it. Yes. So sometimes, let's say, the confusion sometimes is between 2 things that appear similar: asking open questions and encouraging expression of feelings is one of the confusing things. And there are a lot of other confusions also. Although we have rules, one trumps the other, so there's a detailed coding book, but when you're in the room coding, it can become confusing. And when we go into the classroom, Nicholas can talk a little bit more about where these confusions arise. But so if I'm asking you, how have you been feeling? That is encouraging expression of feeling. But if I'm saying, how are you doing? That is an open question. So sometimes the context and the way it's asked can be a little confusing for the coders to figure out. Now, this is something we used to do initially, but we've stopped doing now because it's so resource intensive. Is coding was used to write feedback letters both pre and post training. So we used to write feedback letters to the fellows or the attendings to say, thank you, you did really well in this, but you know, we think you need a little bit more experience in X, Y, and Z, and we would do the same pre and post. But at this point, we've stopped doing that, and we are, although the training directors they want us to do it, but we are, again, it's very resource intensive to write an individualized letter to each person who's coming in for the training, but we are trying to figure out how to do this better. Names of skills and skill sets are reinforced in these letters. So we try to use the same vocabulary over and over again because these are new terms that people are not using. So we want them to be comfortable and start using this. Now I'll talk a little bit about faculty development, because what I said in terms of the hidden curriculum, it's extremely important to involve faculty and attending in this program. Otherwise, you might get a pushback from the senior faculty members. So attending physicians participate in several Comskil modules, are assessed with video recordings, and they receive feedback. Now in 2007, we launched a dissemination project for other New York City area oncology training programs. So every year we have, we offer national training where we also get a lot of international physicians twice a year. And we get our attendings to come, be a part of the training program, and also invite them to become facilitators. Once we know they become facilitators, we know we have a champion who will sell our program in their particular training group. So we invite them to become a facilitator after they've gone through the training program. Now, people who come, the doctors who come for the training program, some of them self-selected. So they've heard about it, they heard good things, they want to do it. Some are, so they might be physicians against whom there have been some complaints, and the senior the department chair, as I would say, or the head might recommend that you go in for this communication skills training program. When they come to us, we don't know why they've come, but they might come via various channels. And so again, as I said, extremely important to attend to this hidden curriculum. We engage leadership of institution through train the trainer programs. As I said, they participate in the program as learners, and then they become our facilitators. Currently, we have a list of 90 facilitators from different disciplines, plus 25 psychosocial facilitators, because we want to have this co-facilitation team, one a clinician and the other a psychosocial facilitator, and there's this ongoing assessment and feedback. Now, assessment and feedback is not only done for learners who participate in the training, but assessment and feedback is also done for facilitators. We want to make sure there is fidelity to the training, so we audio record the facilitators and then code them to see if they are doing everything that we are suggesting that they do in their facilitation. So there is assessment of the facilitators, as well there is assessment of the actors, because
How many people are a part of, like, how large is your staff?
okay, we have, I need to start counting.
Like core fact, like
For our Comskil program, so
7, 8 core faculty that teach in
and
lab.
the people who do coding,
And then we have
1, 2, 3.
3 people who do coding. We have 3 separate people that are in the survivorship program.
Right.
It's a little separate because we're still part of the lab.
Yeah.
And then we have
We have some summer people, because we also strategies and process tasks. We try to code that also. So yeah, we have 5, 7. But their whole work is primarily coding, which can become very exhausting. You're just listening to things and trying to pull out. So our participants are graduate medical trainees, junior faculty, senior faculty, inpatient and outpatient nurses. I talked about assessment. Again, it's also required for ACGME competencies. I've talked about this. Research. All right. I'll talk a little bit about the different types of research we do in Comskil training. What we're doing right now is impact of communication skills training on physician and patient family outcomes. That's the training grant that we have that I talked about. We also have an NCI supported grant on implementation and evaluation of a physician communication skills training module to enhance transition to survivorship in lymphoma. We also have some philanthropically supported grants, so health promotion in underserved populations. We have faculty members studying that, as well as intersection of media and healthcare communication. So these are the different avenues of research that people pursue within the lab. Finally, advanced cancer communication training can be integrated into an institution's regular practice. So all the fellows that come in for fellowship are required to be a part of this training. There has to be a balance between top-down and bottom-up approaches, and that's why it's important to include not just senior faculty members but also junior faculty members, so that everybody's talking the same language and advocating for the program. It's extremely important to have facilitators from each discipline, because otherwise you might say, oh, these people know nothing about medicine and they're just giving us some psychosocial stuff. And that is one of the things that one of the problems that we faced and I was not a part of the lab at that time, but one of the big things was trying to get people to come in, because they said, this is too soft. You know, we have patients waiting outside, we have 20 minutes in hand, so if we could show that you could achieve a shared decision-making consultation in 15-20 minutes, we would have achieved our purpose, and that's what we were trying to do. And so initially, the initial lab members, they went from physician to physician, did office-to-office canvassing almost for the program, got people interested, come in. Once they started liking and became facilitators, that's what helped us, because it became like Train the Trainer program. Future work will also include rigorous evaluation of the effects of Comskil program on clinician and patient outcomes, also on a longitudinal basis. And we can talk more about how to take this a bit further, and what do we do with people who fail the program, and how do we offer consolidation. So I would also like to acknowledge our faculty members and our staff members here. And there is funding from various organizations. Thank you.
So so we had built in 15, 20 minutes at least for questions, and I mean, you're happy to come to class afterwards as well, but why don't you go ahead and see what initial questions you have. Chris Smitha.
Yes.
So I really like that, you're integrating different types of communication skills into the training. I was wondering if you also speak to nonverbal communication.
Those non-verbal communication actually becomes a part of the process tasks that we are suggesting, and we do focus on that. So we'll say when make sure you are sitting at eye level. Make sure that when a patient is talking to you, you don't relax in the back, like this. Make sure you're attentive. So we do talk about body language, but the big focus is on skills, the utterances, the phrases that you must use, the things that you must say. Sorry, I didn't let you finish your question, but
that's basically it. How do you complement what you're saying, those utterances, with the nonverbal aspects of the interaction? So
a lot of that is also covered in the role plays. So we'll tell them, why don't you try having this conversation, relax, sitting like that, and we'll see how the simulated patient responds. And then we'll say, okay, now be a little bit more attentive and see, especially for anger. If you have somebody really calm, or comes into the room saying, hi, how's your day, and the person is really fuming, you can see whatever the doctor says doesn't work, the patient eventually leaves the room and walks out. So how do you enter the room? What do you say to the patient? How do you assess what's going on? How do you assess the temperature of the room, or the emotional temperature, and then start having that conversation? Those are some of the things that we do teach them, and that falls under the process task purview. So yes.
Smith, I was wondering, these are all training, these sessions are for people who already have their MDs,
Yes.
or degrees, so forth. What do you think are the probabilities that this kind of training would be incorporated into the regular curriculum for medical school and nursing school?
So right now they have some communication, but again that is very basic communication. And because these are so context dependent, if they were to have a detailed, communication training in medical schools, it will have to be a whole course or a whole module on it, which I don't know if the medical schools are ready for it. When they come in for the training, they also bring a lot of their experience of seeing patients and hearing patients. The role plays that we build are built from the stories that the fellows and doctors give us. So it's important to have some kind of experience, otherwise it may all seem too soft. And unless they have a little bit of experience, it's difficult to put it into context. So it's good that they are starting to have some exposure to communication skills training, but I think once they actually start seeing patients and get a real experience, it won't be that useful.
Can I respond to your questions, for in-hospital doctors, sometimes they are just not very good with communication.
Right.
However, for the medicine, family medicine doctors, and they are much better. So when I was doing the interview, they were very proud of their communication skills, but not the inpatient hospital. Inpatient hospitalist.
Right.
For those people also
Specialists,
a specialist.
Yeah.
So I guess my questions are I'm really interested in the patient's outcome, as you just mentioned, because a lot of criticism for a lot of research field is you observe the research significance, right? That does not translate into reality. And then so the patient outcome, satisfaction, and everything, I think is very important, right? So that's why you get to level 4, which is
right. We are tracking that. We are right now doing these surveys with the patients, but we have not yet analyzed that data in the second year. But that is something. Yeah, we absolutely plan to, but all the reviews, all the systematic reviews that have come, that have been done so far have shown that the communication skills don't really translate into a lot of patient outcomes. And one of the things could be they're reaching a ceiling effect. They already like the doctor, or they may have changed the doctor if they were not very happy with the doctor. And so if they've changed, if they've come to, let's say, Memorial Sloan-Kettering, they've come with this assumption, we'll see good doctors, they'll be experienced doctors, and some of them also have this paternalistic view that I don't know anything, I'm just putting my life in your hands, and I'll just go with whatever you tell me. And so there's already a ceiling effect in terms of satisfaction with the doctor. We are not seeing that, but our measurement is also very limited. What we are measuring is right now very limited. It's
right, but to come to your point though, some of the outcomes that you can get in something else. Did you take the medication?
Mm-hmm.
Did you follow up? How long did it take you to make the appointment that you needed to make? In other specialties, that makes a lot of sense. But if you're discussing something, that's so advanced and that's that specialist, some of the regular patient outcomes that you'd be able to track from a family med person, you're not going to be able to track.
Yeah, so
Right.
that's why I'm very interested in how you actually measure
patient outcomes. Right now, this is just through surveys, and we're just asking, because we want to tie in with what we are teaching them, we want to show that we are assessing what we are teaching them. Our whole surveys are about communication and satisfaction with that communication. They're not really about how they're managing their illness and if there is medication adherence, etc. But that is what, and leading to longitudinal results is something we haven't really done so far. But
I don't know if this is the case, but I also do research at a hospital in Canada, and one of the outcomes they measure because of the same issue is whether patients recommend this physician or this hospital to others. Maybe that's, okay, you can't apply to everyone, but the fact that they would recommend it to another patient could be
absolutely.
Do you only ask them or actually
The track.
No, you only ask them.
Yes.
Such a thorough study. It really is impressive. I can't remember. I think maybe I missed it. Where the grant is coming from?
From NCI. This is NCI funded.
Sorry, did you want to?
Yeah, is it possible to apply your training experience to other diseases?
To other diseases?
Yes.
Absolutely. This communications training program, the skills that we teach them, they are very basic skills. For example, setting up your agenda, checking understanding, they can easily be translated, from a cancer center to another hospital. So those skills can be translated, yes. Yes.
But I'm thinking about like the characteristics of different diseases. For example, for cancer, there may be like more need to deal with communication on like sudden changes in their illness, like temperature and episode. But for like diabetes patients, there may be a very slow.
Absolutely.
Yeah.
So one of the things that we had done before this program was to do a focus group with patients, with doctors, with different healthcare providers on what they thought and what the patients said their unmet communication needs were, where they felt the communication was lacking or they wanted more information. We're doing right now it's only internally funded, and I did not talk about it, was issues with radiology. So there've been some patient calls or the family member calls, especially for pediatric patients who are going through radiation treatment, or what are some of the long-term effects? What is going to be the effect of the treatment they are getting now on getting secondary cancers? And so is it important to get radiation? Is it not important? So again, the radiologists and the physicists get these calls, and sometimes they are not fully equipped. Sometimes they may not call the radiologist, but may call their oncologist, who is not sure how to answer them because they're asking very specific scientific questions. Now, before we develop a training program, it's important to know what is it that we want to teach them. And so developing a program needs a lot of homework before doing. And I can talk a little bit more about this inpatient nurse, because that's the one where I was greatly involved, was trying to find out what were some of the communication related problems that the nurses were facing. We also did focus group with patients to understand what their expectations were from nurses. What do they want the nurse to be well equipped with in terms of kind of communication? And then came to a discussion, created a program, pilot tested it, changed a few things because they were not really matching, took the role play scenarios from nurses, and we told them, tell us real stories that we can translate into a scenario and use it for our training purposes. So there needs to be a little bit of homework before you can develop a communication program. Yes. Yes.
Have you considered any longitudinal design?
So for what we just described, it's not really longitudinal, but we've just received funding for another RO1 that is looking at when people are told you're done with treatment, right? When they transition from curative treatment to becoming a survivor, again, there's a lot of, they suddenly feel there was so much aggressive treatment and now there's none. They're just seeing their doctor once a year or twice a year. And so there's a lot of distress, there's a lot of anxiety, what's going on, am I going to develop the cancer again, and so on. And so we've developed a survivorship consultation. So and this is right now, we are just testing it on lymphoma, and it's a multi-site study. So it involves 4 institutions. So training physicians to do the survivorship consultation, and then seeing, we are tracking them for 5 different time points. So about a year after becoming a survivor, and we are trying to see
Tracking the patients?
Tracking the patients. So we video record their, so they will have 5 different consultations within the next 1 to 2 years. We'll video record those conversations, and then they also fill out surveys, and we want to see how does this translate longitudinally into some of the patient-related outcomes.
So patient health can obviously be impacted by the communication among the physicians as well.
Absolutely.
And nurses. So I know you obviously have your work cut out for you in this context. Have you considered looking at that and seeing how these modules impact communication among physicians and nurses?
So that is one of the things that people have told us. They would like to see a communication training program on, what is the term used? Intra-professional communication. So we did a pilot of an operating room communication training, because in an operating room there is the doctor, you have the surgeon, you have a technician, you have nurses, you have a senior nurse, you have a junior nurse, etc. So we pilot tested a program on how to have a good communication, effective communication among different professionals who are in an operating room operating on a person. And again, it is in new, it's just we're just testing that, so it was in very, very early stages, but we developed videos and we did some of that, but we haven't really evaluated or done anything yet with the program, but we plan to.
I just had a question, and I was very impressed by all the different waves of data collection that you had, and I know you said that it was very time consuming to send like the progress reports almost to the physicians. How, if you didn't send the progress report though, how do they know that they're doing what they're supposed to be doing?
Okay.
Do they watch the role plays after
No.
to see whether or not they've used this and how this was supportive or not? I know you're interested in the patient.
I'll tell you,
outcomes,
yeah.
To see the adherence to it.
So right now, I'll talk about the informed consent issue, right? So the fellows are required to come and participate in this program. Once they participate in the program, they're also required to do these standardized patient assessments. But do they agree to be part of the clinic recordings is another story, because that is optional. Doing this is more, I wouldn't say mandatory, not everybody has to, but it's highly recommended by the training directors. So after they complete this, we annually meet with the training director and we give them a report card almost, where we say this fellow, for this particular year, fellow A was in the 50th percentile or the 25th percentile range in terms of their communication skill, or was in the 80th percentile and had excellent, this is their pre-score, this is their post-score. So we give individual fellow level data to the training directors and then ask them to, the fellows to contact us if they need specific information about what they were good at, what they need more experience in, and so on. In terms of doing an evaluation and presenting results of the clinic data, because that is supposed to be confidential, we do not provide those results, individual fellow related results, to the training directors. That is an aggregate of overall, did we see a change.
I'm wondering if this pre and post that are not in the clinic, that you're allowed from the coding, can't you just have it
So the-
spit out, like, they hit these targets and we're not good on these targets? So you don't have to spend the time writing the scorecard, but you have like an automatic, they were good at these 3 items and bad at these 4.
So some training programs actually have built up this online assessment thing. We want to do it, we haven't done it. So right now it's very time consuming where you have to go and dissect these conversations and find things. But we are at that stage. But there are some, I believe, and I'm not that well versed in, but there are some online coding software that you can use to see who's good in what. But when we do the training, because it's done for a training program, we cannot tailor the training for each person depending on what they are good at and what their needs are. Although what we try to do when we do these modules and role plays is ask each individual fellow or an individual learner to tell us what is it that they would like to practice. So let's say it's an anger thing and one person might say, I'm very uncomfortable when anger is, when somebody is angry and starts yelling, I don't know what to do. I'm okay if the person is calm and is, etc. So we'll work with them and tell our actors to be over the top angry and scream and do and then do that. So we try to accommodate those kind of individual needs, but that's the maximum tailoring we are able to do, because it's training based and they have to take off from the regular clinic day to come to the training. It's a little difficult to do it in terms of what they were good at. And sometimes because of blinding purposes, actually the SPAs as we call them, the standardized patient assessments, they are not coded until the training is over, because we have to blind them. Otherwise the coders will know this is pre and they might, they might be biased.
So we're going to thank you very much.